Great, guys. Let's see what we got. Okay. Number one, thank you for inviting me out to share something that I'm very passionate about. I have no conflicts of interest to report. I am a husband, father, brother, and son, an anesthesiologist, a mentor, African-American people who are interested in medicine. I'm an author and a child of God. This is my partner, my older sister, Sandy, who's the co-author with me on this book. And this is my team, Jaja and Candace. They basically have a foundation that helps youth in Atlanta. And I've been affiliated with them for 3 years, and they've helped me develop these concepts. First off, can I get everybody to just bow their heads for a second? We'll just take a moment of prayer. Heavenly Father, we thank you for bringing us all together today. You've heard this prayer 1,000 times. We ask that you watch over me, Lord, and help me have crystal clear thought processes so that I may share knowledge that you've put in me in an appropriate way. I ask that you give me a silver tongue so that I might communicate effectively. And most of all, Lord, help me have a heart of gold so that no man may question my goals. These things I ask in thy precious name. As navigators at your respective institutions, my overall goal for today is basically to advance your understanding on the subject of Black maternal health, and I want to position you for action. The learning objectives that we have, we're going to be teaching you about Black maternal death, and by the numbers. And what I'm going to do is give you some key numbers that help you with that elevator discussion, or help you with that short discussion you have to get people in your sphere to understand the importance of this and the urgency of engaging this issue. I'm also going to talk about some of the causes of the Black maternal health crisis. And we're going to introduce some people who are doing it right. And just so that you can get an understanding of all the people who are moving and the players in the sphere, the players in the Black maternal health arena, the people who are trying to solve these problems. Basically, after that, what we'll do is we'll run through the story right quick, and I'll show you how we integrated the messaging and the information that we have into the story. The tools that you guys should have received, there's a Black maternal health survey link for the Dream House Make a Difference Foundation. It's only about 5 or 6 questions. I'll ask you to fill that out as we go through, or fill that out in between in one of the short breaks that we have. There's an audio link for the quote makers. And we had a professional woman do a great reading of this. And the reading really just takes the story to another level. I gave you guys a link, a Dropbox link. I'm going to keep it up until about the 10th or 11th. My hope is that, you listen to it and, and continue to learn and build on this. But other than that, you have a PDF audiobook companion that really has some of the references that we use in terms of making this story, and that outlines how we basically use art to heal. Let's start off with session 1 by the numbers and stuff. And basically, and of course, our learning objectives just to get those numbers. The question comes, hey, how did I get involved in this space? And the reality is I'm an anesthesiologist, and I took care of a patient for a C-section. We ended up getting out and going to the recovery room. And then in the recovery room, she cut loose and started bleeding. And we had to go back in and save her with a transfusion of about 15 units of blood. And it was a massive piece of work. Well, what it is, whenever anything goes wrong in the OR, we have to do a quality assurance write-up. When I started to do the review for the quality assurance write-up, lo and behold, I started to run into all of these issues about Black maternal death, and come to find out the #1 risk factor that this lady had for having problems in the OR or having a child was the fact that she had brown skin. And that really just put me on a path to trying to understand. The numbers I give you are all tied to people. And you may have heard some of these names, like I think Kyra Johnson's, Judge Hackett's daughter who passed away. Tori Bowie was an Olympic champion who died during surrounding childbirth. Dr. Janice Wallace is another. She's in the Midwest and was a physician, well-liked physician. Serena Williams was nearly died. She had a pulmonary embolism and really had problems with the system hearing her when she died. But one of the things that all of these mothers assumed when they got pregnant in America was that they had some rights. And there's some common sense reproductive rights that every mother should have, and that is the right to be safe, to be respected, to have care that's available, accessible, and culturally acceptable and of good quality and stuff. But one of the things that we have to keep in mind with the pregnancy lasts for a good period of time. And whenever we talk about deaths from mothers surrounding pregnancy, we're actually talking about the time from the point that they do the conception to about a year after delivery. But the sections or the phases are the preconception phase, the antepartum care phase, the intrapartum care phase when you're delivering, and the postpartum care phase. Now, the key is, just so we have common terms, you're going to hear people say morbidity, maternal mortality rate, MMR. That means the number of deaths that occur per 100,000 live births. Another phrase you may hear see is SMM in your orientation. That basically means the number of severe injuries or near deaths that occur per 100,000 births. So if you look at Serena Williams, she would go under the category SMM, or a near death. But the problem is, just like I'm military, so anytime we take soldiers to the field and go to war, we keep a ratio up for every death. How many major injuries are there? Okay, so normally right now, if you got one guy who's killed, you're going to have, you may have three to 8 injuries associated with it. Well, the key is, for every one mother who passes away in America, it's thought that at least 100 other women experienced a near-death event. The numbers I want you to remember. First, you got to remember double or 2 times. In the last 20 years, the death rate for mothers, all mothers in America, has doubled. But in the rest of the world, it's actually decreased by 40%. So America is one of only about 7 or 8 countries where the trend is going in absolutely the wrong way, okay? When you look at it, basically, the problem with this maternal death rate, you can see that America, for industrialized countries, far outranks people in terms of the numbers of deaths and stuff. If you look at New Zealand, they only have about 1.7 deaths per 100,000. Finland maybe has 2 to 3 at the max. But the bottom line is, you can always see that other industrialized countries, for some reason, are moving in the right direction and have very, very low death rates for mothers across the board. In 2018 to 2020, there was actually a 40% increase in the number of deaths that occurred for mothers in America and stuff. So not only has our trend been going bad for the last 20 years, it's accelerating in a bad way, a negative way. Now, because of this, the World Health Organization, UNICEF, all of the international bodies have basically, identified, the United States as a hotspot for intervention in order to try and improve mothers' lives. So basically, the second number I want you to remember, other than the fact that double 2 times, that the rate of deaths for mothers in America has increased by 2, is 3. And that is that Black women die at 3 times the normal rate, okay? They die at a 3 times higher rate than other women in America. And that's one of the reasons why we're here. Again, we talk about mothers who pass away, but one of the things I want to try and focus you on early is when the mothers pass away. And that ties us into the third number I want you to know, and that's 60%. So if America's doubled or increased the number of deaths overall times 2 in the past 20 years, and 3% of Black mothers are dying at 3% of the Black women die at 3 times increased rate. I need you to understand when those mothers are dying. And actually 60% of the deaths occur after that child is out. So if you remember, you got the joyous part of the getting pregnant, you get the 9 months of growth, you get the excitement of going in and having a baby. But once that baby comes out, that's when you enter a red zone, okay? And I think in all of the studies I've been doing, that it's that red zone where I try to focus and try and get people to help with the intervention and stuff. So when do the deliveries occur? That's really saying the same things. It's just that first 6 weeks after that child is out, I consider that to be a danger zone. The last number, so we started off with the death rates are doubling in the past 20 years. 3% of Black women die at 3 times higher rate. 60% of those deaths occur after the child is out. And this is the most sobering number. And it's taken because of the urgency and because of the negative trends in that have been out. States have basically established maternal mortality review committees where every single death that occurs in a state is reviewed by a team of different doctors, surgeons, pediatricians, OBGYN docs, all types of doctors, and they come up with a reason why that mother died. So anytime a mother dies in about 40 states, that process occurs and stuff. But the number that it came out is with is that actually 80 to 84% of the deaths are avoidable. So not only are mothers dying at a higher rate, but most of the deaths that occur are preventable. And that basically, those are the numbers that we want to tie into to keep you in that urgency. 60%, 80%. But the reality is I'm of the age right now where if I see a problem, I don't always just point it out. I try to solve it. And fortunately, for the past 2 years, I've been on a grant with the Gilead Foundation to do some work with a short story I wrote on breast cancer prevention in African American in the younger African American women. And so what I did was say, well, look, if I can do that, do it for that book, which is called Non-Native Bush Woman, maybe I can do it for this book. And what I did, the way I started out was to go to a colleague of mine who's an obstetrician with over 30 years experience. And I asked her a simple question. If your daughter was about to have a child, what are the 3 things that you tell your daughter in order to keep her safe? And this is the message. And that was the message we started off with the quote makers. The first one is a woman's pregnant 45 weeks, 39 with child, 6 weeks without child. Okay. And you're not out of the zone until that 6 weeks. This has actually been expanded to a year by the CDC. Okay. The second point is speak out or shout out in the hospital and use patient advocacy early. She said, I tell my daughter that the system is tone deaf to Black women. And what you have when you review a lot of the poor outcomes where African-American women are having problems, the African-American women are actually following the instructions. A lot of times they're seeing symptoms of having problems and they're presenting to the emergency room, but they're not being heard. A lot of times they're reaching out to the medical establishment, but they can't exactly hear them. And in fact, as late as 2016, when they were looking at a group of University of Virginia medical students, they found that upwards of half of them still held on to stereotypes, such that to believe that Black people have thick skin and African-American women have a higher pain threshold than others. You know, and just completely stereotypical and racial, but they held on to them into this modern age. So the reality is and being heard was a common theme across that we learned across in studying this. So it's not that our Black women are not going. A lot of times our Black women are not being heard. And guess what? It doesn't have anything to do with your educational level, because they have studies that just came out from California that showed that if you are a college educated Black woman, you have a worse outcome than a non-high school graduate white woman. They do, for some reason, the system doesn't hear you. My friends, if we try to promote through the Be Edmond project that if you engage 2 times with your support system and they can't hear you, then that means get patient advocate involved early. The next is the prenatal visits, and we say 8 is enough. If you look at the World Health Organization, they suggest at least 8 prenatal visits and 4 post-natal visits. One of the problems is in some systems, the postnatal visit was being placed up to 6 weeks out. So in other words, the postnatal visits weren't during the time when you were in that red zone after delivery. The fourth component that we added to the book was just something that's not always mentioned above board, but it's sexual assault in the Black community and its impact on healthcare. The net effect of what I did was take that medical message and basically blended it into a nice, tight, short love story where the focus is on art called The Quilt Makers. But one of the things that happened after we did The Quilt Makers was the CDC basically was able to publish their website, which is the reference and go-to site for Black women having children. And one of the things that we're promoting is that every single Black family should become familiar with this site. They have posters, handouts, anything you need to run a program to educate people on this issue. The other thing that they have are video discussions, and just it's the greatest site. And it was created by the CDC because they had their sense of urgency. So I had my sense of urgency and wrote the Quilt Makers, but I was followed by them, and they had their sense of urgency. The beautiful part about the Quilt Makers is I used a lot of the same reference sources that they use for this site. So one of the things that they focus on is trying to teach people to recognize the maternal warning signs, the signs when a Black mother's in distress. Well, the bottom line is we use those same symptoms and put them in the short story. So you're able to actually see the symptoms, but instead of them being on a list like this, you're actually able to see how the patient feels when she's going through those symptoms. Each one of the symptoms, basically, most of the symptoms deal with either the effects of blood pressure and elevated blood pressure, the effects of bleeding, or the effects of blood clots in the form of pulmonary emboli, or clots that travel from your legs to your lungs, or infections, okay? So some of those symptoms that we teach and that we hope as you establish your program at your church and within your community, that you get the support system, the mothers, and the support system to understand and learn these symptoms so that they can help amplify the mother's voice during the pregnancy phase. So when the mother, it's tough to be pregnant, 8 months pregnant, and having a headache that won't go away with aspirin, and then having to fight with the authorities as well to protect yourself while you're trying to take care of your child. So the reality is some of the symptoms: dizziness, vertigo, visual changes, if you have extreme swelling of the hands and feet, nausea, severe nausea towards the latter part of pregnancy, severe abdominal pain that's super out of the ordinary, bleeding at any time, and severe swelling, and somnolence and tiredness. So, but once again, all of those deal with either blood pressure, bleeding issues, blood clots, or infection. But let's look specifically at how Black mothers die, okay? And basically, when you look at, you have other complications, but if you look at the dark blue, preeclampsia and hypertensive issues are the #1 things that take out mothers. But there's another thing that affects Black women at a higher incidence, and that is, if you look at the dark green, it's postpartum cardiomyopathy, postpartum heart failure. Now, heart failure and hypertensive emergencies, they present the same way. And heart failure almost can look like a flu because you have some nausea, you may have swelling of the retaining of fluid, swelling of the ankles and the hands, which can happen during pregnancy. But one of the things I keep in mind with the heart failure, it can happen at any time during pregnancy, but a lot of times that heart failure goes until about 6 weeks out. And I think at about 6 weeks, the incidence of heart failure drops to about 12%. But the bottom line is, these are the 2 killers for Black women we want to really focus on. That is hypertensive emergencies and heart failure. When we talk about hypertensive emergencies, we divide them into like something called preeclampsia, and the other one's called HELP syndrome. Preeclampsia is basically uncontrolled hypertension. And the reason you get uncontrolled hypertension is because the baby's placenta releases hormones that make the mother's blood pressure go up. So it's almost as if you're looking at, it's like, it usually has a situation where the placenta is not really functioning 100% and in full force. So because the placenta might not be able to allow nutrients and blood to get into the baby easy enough, it's almost like the placenta releases hormones that raises the mother's blood pressure so that you can force and push more nutrients into the child's bloodstream. But they're hypertensive syndromes. And the first one is preeclampsia. And the second one is HELP syndrome. When we talk about HELP syndrome, some people, you may have heard of toxemia. You may, but when we talk about HELP syndrome and preeclampsia, some people believe that they're a continuum. And with preeclampsia, you get your dizziness, your headache. But one of the things that people tell folks is that watch your blood pressure so you don't get preeclampsia, but they never tell you what happens if you don't check that blood pressure. We never really get to see the end point. And that's one of the things that we're allowed to do in the Quilt Makers. And I basically describe a woman in appropriate clinical terms in terms of what happens to her when she develops preeclampsia that progresses on into HELLP syndrome. Okay, and the timing is correct. And if you notice that when you get closer to delivery dates, or once you get past the period where the placenta is developed enough to secrete those hormones and cause hypertension and preeclampsia, they check your blood pressure a lot closer. And they want to check you really sometimes within every week or every 2 weeks, because if it gets out of hand, it gets out of hand very, very quickly. But if you get into HELLP syndrome, it's actually 25% fatal. Okay. So it forms because you have a breakdown of red blood cells, you have your liver starts to fail, and that's why women have the right-sided abdominal pain problems, and then you have the low platelets that can develop. I'm glad I'm talking to some people who are in church and some people who know Jesus, because just as sure you have physical causes of death for Black women, you actually have spiritual causes of death for Black mothers. And mental health is one of those. But then the other killer, believe it or not, is homicide. And I list that as a spiritual because it deals with the safety that's happening in a home. And actually during pregnancy, homicide deaths for mothers, it's responsible for more deaths than bleeding, hypertension, and infection and sepsis combined. So, and then 68% of the time when they kill the mother, they do it using guns. So what's really happening and what you can expect in the future is there to be made a public health tie between access to weapons and guns in household and maternal health, okay? But I give all those numbers to you so that you can understand the urgency of the situation. Let's stop for a second and I'll take some questions, guys. You have some questions for me at all?
Hi, thank you for this presentation. I had a friend who had a similar issue where the doctor, while she was at the hospital after birth, told the doctor she wasn't feeling well, and he dismissed her. She went home and took the baby to the pediatrician, and and she complained to the pediatrician she wasn't feeling well. The pediatrician then called her doctor and said you should check her for that health condition use suspension. And
Yep.
then the doctor allowed her to come to the hospital immediately.
Right.
So my question is, what can she do to advocate for herself? Because she said before she left the hospital, she kept arguing with him. I'm not feeling well. Something's not right.
Right. That's the
And
key.
he didn't listen to her.
The phrase you said, something's not right. And that's why
Mm.
in the book, and if you remember what my OBGYN friend said, she said, you got 2 times for me not to be heard. After that, you get patient advocacy involved, okay? And one of the things that we do with the Be At Me Project is explore that concept of how comfortable you are. In the survey that I want you guys can click on and kind of take. In the survey, one of the questions is, it has to deal with how comfortable you are using patient advocacy, okay? The other
Oh, I'm
thing,
very comfortable, but I don't think they gave her that as an
right,
option.
right. No, the patient gets to call patient advocacy. And
Right,
so
but while she was in, that's what I'm saying, while she was in the hospital, I don't think they told her that was an option. It was like, you
right,
have to be
absolutely.
discharged today.
That's why we are hipping everybody. That's why we're hipping them. There's somebody on every single, there are teams of people at every hospital that are responsible for working and improving communications between the doctors and the patients. They're on salary. The key is we're training people and letting them know that these people exist at the hospital. So they have the hospital's resource with this, but our people don't know that, hey, yo, if I 2 times and I really don't like what I'm hearing, you got options. You can go to the patient advocate. And the patient advocate comes in and talks to the doctor, then they talk to you and they say, hey, yo, she doesn't feel like she's being heard in terms of this. And that's how they fix it. But one of the other things that we do in the story, and you really tied into the crux of the story, and the full title for the book is The Quilt Makers, The Art of Hearing a Black Mother's Cry. What we use the tradition of quilting and such to bind the community around that mother, so that whenever that mother has to say something, her voice is amplified. Okay, and
Yeah,
I'll show you some more things on that in a little bit. Any other
thank you.
questions?
Yeah, well, I'm sorry.
Yes.
Is the questions in the chat?
Oh,
The link is in the chat you're sending? Because I don't see it. Just FYI.
Okay, chat. Okay, on here. I got my chat right here. What are recommendations for taking prenatal pills? How early should women start taking them? The bottom line is for prenatal pills, we talk about with prenatal, if you remember, we divided the let's see what's 1 second, bear with me just a second. We divided having we divided having kids um into 4 sections. The preconception care phase. So we actually want mothers to start preparing themselves for this thing, before they get pregnant. And you want to address those chronic illnesses, the diabetes, the hypertension, the being overweight, the smoking and stuff. If there's a way to do that, then we want you to do that for sure. With prenatal violence, it really, the taking of the prenatal vitamins, and then that when you get pregnant, go ahead and start taking it, and start accepting the guidance that they have, in terms of improved nutrition for that child. I do want to mention one thing, and that is that a lot of people don't know that in some places, because of Medicaid, if once you get pregnant, you actually are eligible for extra funds so that the mothers can get quality fruits and vegetables. Okay, and so when you're pregnant, something changes a little bit. Okay, we're gonna try. Can we? Let's see. I'm gonna ask either Melissa or a team if they can post the link for the link for the survey. If you can post the link for the survey in the chat group, that'd be great and stuff. Okay, so you guys can.
Yes.
All righty.
While
Post
they're
it.
doing that, can
Yeah.
I ask, is there a patient I can't say the word, advocacy department? I mean,
Yes.
how do they find this help?
That's it. All you got to do in every hospital, just ask. All you got to do is tell the nurse, "I'd like to speak to patient advocate," and it's it's with in America, they have to have it according to JCO. So in other words, in order to be a credentialed healthcare facility in America, you have to have a means for patients to discuss and engage if they don't feel like they're being heard. Gotcha. Okay, I think she just posted that up. Okay. Any other questions?
I just wanted to make a statement that if you work in a hospital, you kind of know these things, but
Yep.
if you don't work in a hospital, you don't know.
Absolutely.
There are patient advocacies, and they are employed by the hospital, and that is their main function, to deal with the issues of the patients. And
Right.
even if you don't get satisfaction there, the next words that should come out of your mouth is the administrator on duty.
There you go.
And I promise you, something will happen.
They move. That well said. Well said. Okay, guys. What I'm gonna do, this is April Valentine. Um, she's from Los Angeles. She had a full plan on how she was gonna have her child and deliver her child and everything with a doula. And her team, her husband, they had a laid out birthing plan. They go into the birthing plan and they don't follow the birthing plan. April ends up having a child. She in the hospital. She's having problems breathing, having major issues, and once again couldn't get people to be responsive. And April ended up passing away. Very quickly as we make the transition, what you're going to see is we had one of the Delta Sigma members of Delta Sigma Theta read the book, and she basically insisted on making a quilt for us. And what we do in terms of using tradition for the story, we basically use patterns from the Underground Railroad to help serve as a guide for how mothers are going to be doing during pregnancy and stuff. And so it's part in the story we introduce the symbols for the Underground Railroad that are on quilts. But very quickly, what I want to do, if we've already talked about Black maternal death by the numbers, let's talk about some of the causes. Okay. Causes can be individual causes. They can be relationship causes, meaning relationship with the community, with your hospital, with your care support system, with your family, and also can be on a community level and then on a societal level. Basically, we already mentioned about the maternal warning signs in terms of blood pressure, bleeding, blood clots, and infections. So when you're looking at the individual level, each one of these issues can be tied or have different people can be at risk for some of these symptoms. I'm only going to use one, and that is, say, preeclampsia. The risk factors for people who are the individual risk factors, we're talking about the individual, for risk factors if you had it before, if you're having multiple children like twins, if you have if you have diabetes or autoimmune disease like scleroderma and lupus, which of course affect the Black community a lot. Those are high risk factors. You also have moderate risk factors like being overweight. They actually list being African American as a risk factor over the age of 35 and a low socioeconomic status. But one of the concepts that I want to introduce to you is the concept of weathering. Basically, what they found was that they believe that there are factors in society and based upon race and the dealing with race and the stress of being a Black woman in America that basically ages the Black woman faster and ages the Black man faster. And they believe that that's one of the main reasons why Black people who have heart disease, hypertension, or diabetes or strokes, their outcomes are worse because they almost believe like there's a aging process that occurs. And when they look at the DNA over the years, for people who've been exposed to the stress and the difficulties that come with racism, they actually see physical changes occurring called methylation, where physical changes occurring to the DNA. And so when we talk about weathering, what that means is if I have a 35-year-old Black woman who's laboring and about to have a child, they may labor and have a child as if they were a 42-year-old Black woman, okay? So in that situation, the risk is higher. If I have a 25-year-old who's supposed to be in their prime of having a child, they may labor as if they're closer to being 30 or 32. So where there's a little bit increase of problems. And you say, well, hold on, man, this weathering thing, that sounds just a little too much. One of the ways they really identified the weathering was they actually looked at when it's safest to have a child if you're African American in America. And what they actually found is that the Black women who had their children in their teens did better than the Black women having their children in their 20s, which is when in their mid 20s, when they're supposed to be at their physical best. And so that's why they really believe that there's stresses that occur that Black women are subject to that actually impact the outcome. But that's an individual thing because different people have to undergo individual experiences that cause different levels of stress in their life. Other contributors are healthcare systems that's not attuned to mothers, the inability to be heard by the system. I forgot the name of the sister who gave us that example of her friend, but that is the classic component. The mother knows something wrong and is saying it to the system, but the system just can't quite hear her. Unfamiliar healthcare environments, not understanding, like we said, the guys who work in the hospital know about patient advocacy and know that we can call somebody, but if you don't work in this environment, you don't necessarily know. But then also bad experiences. If you had an experience when you were younger, you might not be excited about dealing with people and you might just dealing with people and ready to fight tooth and nail for your health. But all of these things can contribute. Your relationship to your healthcare system can contribute to that. Now, one of the things that Johns Hopkins did to help address this hearing component, what they did was set a blanket policy that any woman who comes into the urgent care center or their emergency room, if they are pregnant or have been pregnant within the past year, they have to be seen and examined by an obstetrician or fellow within about 45 minutes to an hour. It's the policy. And the reason for that is that means that that within an hour, no matter what's going on with that woman, she gets hands laid on by somebody who's familiar with her, with the mother's physiology, who can hear her better. You see? Again, we talked about individual causes and relationships with your workplace, but then there are also community issues. And most of these things are called the social determinants of maternal health. These are things that are non-medical that have been proven to affect your outcomes, like food stability. I'm not going to read the list because we have, I'm not going to read the list, but because we have because we have because what I want to do is take you into the way I remember it, okay? And the only thing I do is I remember one quick question. I asked myself this question: what did Joseph and Mary need when they had baby Jesus? So when we look at baby Jesus, he was born where? In a manger. That's pretty unstable housing, isn't it? Mary and Joseph weren't in their home place. They didn't have their full network to support them. They had to travel to Bethlehem. Well, how safe was it where he was born? We think it's pretty safe. He had his mom and dad there to fight for him. Nuh-uh. Because when the three wise men saw Herod, Herod said, what? Let me know where the new king is so I can praise him too. Literally, he once the three wise men came to Herod, he was under an umbrella of threat to his life. It didn't take Jesus's life, but it took every other male child under the age of 2. It took their life, because when Jesus and them left, the Herod came back and killed everybody there. So the question I ask is, what did Joseph and Mary need? This is a simple way for you to really get tied into that the non-determinants of health. And let's talk about, in the way I do it, is say, okay, well, you know, what were the gifts of the three wise men? Okay, the gifts for the three wise men: they brought gold, frankincense, and myrrh. They brought frankincense. You can light it. It's almost an incense, a royal incense. It brings us a sense of pleasing and royal and smells and stuff, and a sense of well-being. Being born in an environment with low stress, low threat of violence, where everything's controlled. Myrrh is actually was used as an antiseptic and also used as a pain agent. And if you remember, when Jesus was on the cross, they offered him some wine with myrrh. Okay, maybe to take a little bit of the pain away from what was going on. And then the other thing is gold. And what that gold allowed Joseph and Mary to do, it allowed them to travel to Egypt, get fully resources. They could get the housing together. They could travel. They had transportation. You have the myrrh that Mary could use for health and wellness and such. And so all of those things I've mentioned: health, wellness, travel, security of food, security of house, living in a decent neighborhood where there are no threats and less stress to you. All of those are the social determinants of health. And I hope that made it easy for you to remember. Again, food stability, education of the parents, of income, neighborhood demographics, safety, housing. But there's another thing that actually plays a role in terms of the cost in America, and that's insurance deserts. And in insurance deserts, sometimes you can have access to care, but it does you no good to live next to access to live next to something that gives you good care if you can't go in there and use it. So the bottom line is, in America, if you remember, for Medicaid, they usually cover prenatal, delivery, and postnatal for 12 weeks and stuff. Okay, well, after 12 weeks, after that 60 days, a lot of people don't have enough money to purchase more insurance, and they may be too rich to stay on Medicaid, but too poor to get their own insurance. So they fall in the gap, and Black women fall in the gap more, okay, during that period. But if you compare what's happening in other countries, you know, in other countries, they believe in insuring their mothers and children. So the key is the access issue is addressed and stuff. And thank God for for Biden. What he's done is has made it easier for different states to actually extend that 60-day period out to a year. Okay. And even in the state of Mississippi, they're extending it out to a year to keep some mothers on Medicaid. So it's giving people more resources to address the issue. But we have to take into consideration the deserts that occur from the insurance deserts. Another desert is actually your maternity care desert. When we talk about maternity care deserts, and these occur in Black communities, if it takes a long time to get to basic quality obstetrics care, that's one thing. But then it may take even more time to get to quality upscale high risk care. Okay, And that's where, and so in America, America's one of, in the deserts are dependent upon the workforce, what you have, the workforce and access in America. And that's really kind of where America differs and stuff. So just because you live in a city, it doesn't mean like in Atlanta, you know, and I mentioned it yesterday, in Atlanta, they have a case where a child was mutilated as they were born and stuff. And that was obviously a more difficult, challenging, probably higher risk delivery. Okay. The question is, you know, with that couple, how much access did they have to North Side and the other centers where you can handle more high risk pregnancies? That's a question that we have to ask ourselves and stuff. But the other change that's different in America is the workforce. And the quilt makers deals with midwives and talks about midwives, but the only two people who catch babies are midwives and physicians, okay? But you also have people who are playing larger roles in Europe, but also now larger roles in America called doulas, all right? When we look at the, but when we talk about workforce very quickly, I have to mention something called the Flexner Report. In short, what they did in 1910, they went around, looked at medical schools, and they formed a model of healthcare that basically allowed the Caucasian male to be the gatekeeper for all of medicine, including the delivery of children. They basically put the midwives out of work, saying that that children didn't need to be delivered in the home, you need to be delivered in the hospital. Well, in the 1930s and 40s, actually, believe it or not, 75% of rural people who were born in the country, 75% of them were attended by a midwife, okay? And let's ask yourself the question, for thousands and thousands of years, delivering babies has been a woman's realm, okay? How in America did it get away from that, okay, and not become a woman's realm? And part of that has to do with a conscious decision in terms of who's going to be controlling the deliveries and birthing babies in America. And and they set it up so that when they looked at the medical schools, they knocked off a lot of the Black medical schools that were in existence. They closed down all of the medical schools that were educating women in the 1910s. And then what they did was basically only schools that could be kind of like Johns Hopkins were the ones that they supported financially through Carnegie and Vanderbilt and those guys. So with their money, they dictated that the Blacks, women, and people who were working class trying to rise, that they were excluded from medicine and stuff. And so, and that has had an impact, because you got to remember, 100 years later, that's about 40,000 Black physicians that should have been in our community. How many women physicians should have been in our community? And that's really one of the main differences when you start looking outside of America, is the workforce difference. The workforce, other places in Europe and all of those developed countries where you have have better outcomes, all of them have midwives playing a larger role. Let's look at Australia in terms of OBGYN deliveries versus your workforce versus midwives, which is the pink. So if the purple is the doctors, the pink is the midwives in terms of their role. Let's go down and look down here at the United States. You see, you have OBGYNs are the ones who are dictating it, and you don't have enough midwives even for your workforce. So that's why you have these medical deserts. You really don't have the workforce to take care of the people that you have. So if you look at Finland, for example, in Finland, in Europe, in Poland, the people who actually deliver the children for a young, healthy patient, the two people that deliver the children are two midwives. Now they're under the instruction by an obstetrician. If they run into any problems, you have an obstetrician available who can come get them, all right? The other player that I want to mention are the doulas. Doulas are well penetrated, over in Europe, but the reality is we used to have doulas too, and it was called Big Mama, or that cousin that would come stay with you for 6 weeks. For every person who was in the family who had a child, there'd be this family member who comes stay with them for 6 weeks, and this still goes on in Ghana. You have cousins that come stay with the mother to help with the house, take care of the mother when she delivers. They're there helping to teach the mother how to suckle, taking care of the mother, making sure it's a low stress environment, and being an advocate for those mothers. One of the things a doula does is it's as soon as you get pregnant, they start coaching you up on the symptoms. These people are trained for the signs of a mother in distress, but more important, they educate you about the system and the process of having a child. They help you develop your birthing plan, and then they'll be there in the room with you, helping you labor. Afterwards, they stay around, help you, teach you how to take care of that child. But you got to remember, guys, a lot of our families travel. You know, I live up in Maryland. My family, most of my family's in Georgia, all my sisters and cousins and everything like that. If I'm up in Maryland, you know, who do I actually have that I could trust to treat my wife and take care of my wife, you know, when I'm still working and earning, trying to take care of things. And so 21 years ago, I had a doula to come do this. And what it is there are doula programs, I think, in New York, but I do want you to understand that in some states, doulas get paid by Medicaid. So in Louisiana and a lot of different states that are recognizing a workforce that's not, you know, really well established, where they don't have enough workers, what they're doing is basically doulas get paid. And because and it's not just off the whim, they get paid because the outcomes for mothers are better when you have an advocate, a professional advocate who's helping to coach you along through the entire process and stuff. So the bottom
Dr.
line,
Evans,
yes, ma'am.
do you know of any doula programs in New York?
Gotcha. I don't know of any offhand, but I wouldn't be surprised if they are there, and they are there. And I have some friends looking for some in Atlanta, but you actually have to look in Google and look around for them. But I'm pretty sure that they're somewhere. This is really widespread. But the deal is, they act like it's something for high-end people. The reality is, it's like I said, it was really just that person, that big mama, who would come and stay at the house, you know, in time. Okay. But then, yeah, they put something on the wall for you. So we also keep in mind, we have nurses and specially trained nurses that take care of you. So you have the two catchers, the baby catchers, are the midwives and the doctors. Okay. The last learning objective we have is to introduce you to Mother's Health Support Network. Okay, so if we've already been exposed to the, you know, the things that cause the societal causes for health. We've been exposed to, you know, some of the risk factors a little bit. But let's talk, and we've already talked about not being heard and things of that nature and the importance of advocates. Well, the bottom line is, let's look at what some systems are doing. And the system we're going to target is Casa Permanente. And they basically have a cocoon model. And what they do is they put that pregnant mother in the center of the model, and they basically tie her into direct providers. You have, this is an ideal situation, but you have an obstetrician, nurses with midwife, you have pharmacists, social workers, you have doulas that are there working with them. And that's more so the inner circle. But what I want you guys to focus on is kind of the outer circle. On the right, look at this thing, telehealth and remote monitoring. The whole idea of having to come in for your prenatal visits and stuff, or postnatal visits, with telemetry and stuff, with telehealth, it's getting easier and easier and easier to do. You see them coming from? The other thing is, how do we to monitor? The other thing is understanding socioeconomic support for this. And that's why, because this issue was such a crisis, there's actually money out there in the form of grants and things of that nature to help with the cause. One of the things that they look for is proper finance and stuff for paid maternity leave. In America, you can get, in some places, you can get 12 weeks maternity leave that's non-paid. In the UK, you can get 30, you can take a year off and get 39 of those weeks paid. Okay. So literally you can have a child and not have to go broke and everything. And I think that those are some things that other communities are doing, that America is just not quite not into yet. But we're coming along slowly but surely in terms of getting time for the mother and time for the father to bind to them, and understanding that doing that while you maintain a stable household or a stable income is important stuff to the role. When we talk about countries, there's one reference that's going to be on one of the my sheets to Finland, and I refer to that very quickly. I'm going to take you through what happens when if you have a child and you're in Finland. You basically, as soon as you get pregnant, you get assigned a nurse, and that nurse basically helps coordinate your prenatal visits. You have about 8 prenatal visits. On your second visit, you meet the obstetrician. On the last visit before you deliver, you see the obstetrician again. In between, you're meeting with midwives. And you're also attending classes on a weekly basis that are run by doulas and midwives about the process of having a child. Their focus in these countries is to have a vaginal delivery. They really focus on a vaginal delivery in these countries and stuff. When you deliver, they actually have community-based systems where you can deliver at kind of like smaller community hospitals that are in the community. In America, everybody wants to send your kid to see the Sinai, or you want to send your kid to the local medical center, okay? But these guys have birthing centers and stuff in their community that are staffed by the midwives who you've seen and backed up by the obstetrician. If at any time they see anything that's out of the ordinary, they'll send you to the medical training, the big, larger medical training facility. That's a structural difference in terms of our healthcare system and other folks' healthcare system. Before the child, as soon as the mother gets pregnant, guess what she gets? She gets a gift box. She gets a gift box with a bunch of different things, enough equipment to take care of that child for the first year of their life. You get a bassinet, the bottles, bassinets, clothing. For every child born, and Finland has been doing that since 1937. In 1937, they had a real high death rate for mothers and children. What they did, they implemented this to give them to start giving they call it the cardboard box. When they did that, the survival rates were so good that they started implementing it for every child born in the country. Okay. So the key is, it's almost like three wise men coming every time you have a child. Someone's providing extra resources that you need to take care of the child. Right now, if you have multiple kids, if you don't want the equipment, you can take about $650. They'll just give you $650 to help you get where the kid's going to be sleeping and all that taken care of. But moving right along, the other thing is they got insurance. So that child basically has insurance up until about the age of 7, and then they'll transition over to a school insurance program and stuff. But those are differences between us and the Finnish system. And you might say, hey, Dr. E, why are you so hyped on Finland? I'm not hyped on Finland. What I am hyped on is making sure that everybody in the sound of my voice understands that the problem of maternal death somewhere on this planet is already being appropriately addressed. You don't have to reinvent the wheel. Just find out what system that's going on other places, what things going on in other systems match up with your resourcing, okay? But and that's the most important thing I want you to understand is this stuff is avoidable, all right? And that's why I'm kind of involved in hype. Very quickly, I'm only going to take about 5 minutes to talk about the BEdmin project. You guys have the survey. I'll ask you to do that, but I told you guys how I got involved with that case. This is my sister again and stuff, who's my co-author. What our concept is called is using art to heal. And what we basically do is we educate people using up-to-date data and information, but we use art themes. And we also use a nice quality story. I want you all to listen to it on the audiobook. Can you post the audiobook, the Dropbox audiobook? I'll keep it up until Saturday or Sunday. It's a great listen and stuff. We use art. We had a digital artist to do this, and there's something about Stella that just stands out. We have the quilt made, that's my background, but also the quilt, basically, if you look at the silhouettes, they're basically talking about the progress. If you look at the bottom, the woman gets pregnant, she prays, she progresses to delivery, and by the time you reach the top of the silhouettes, the top of the quilt, it basically outlines a mother who's successful. And we use 4 of the common patterns from the Underground Railroad and stuff. We also have a true artist involved on, I think it's page 25 or 49 in the book. What happens is Ruud van Empel, a digital artist out of Amsterdam, we use his piece for discussion. There's a love story in there between these 2 college kids who kind of fall in love over an art class. And the bottom line is we use that as an example. When I asked him to use it, he said, I told him that we were trying to write a book to decrease the incidence of death for Black mothers. And he said, I'm going to give you this letter. You can use it. You use it in every printing of your book. And the only thing I'm gonna ask you is just give me a copy of the book once you made it, stuff. And I thought that was gracious. I've never met that guy face to face, but what we also do is use traditions. I am from middle of Georgia. This is my great grandparents, the Mackeys, and this is Stella right here. Okay, Stella. We didn't know about Stella when we started writing the book, I asked my dad who delivered him. He said Aunt Stella. I asked my cousin who delivered him, and she said Aunt Stella. Come to find out, Aunt Stella was one of two midwives active in Lawrence County and stuff in the 1910s through 1930s and stuff. And I was able to actually sit and interview her son, Bobby Pryor, who was 100 years old. And he was able to give us information about what it is like that, what it was being the son of a midwife. We've already talked about these components. We wove these components into the story, but they're themes, powerful themes on sisterhood, powerful themes on how the concept is working with what you're given. And any true mathematician knows the first thing you do is you ask the question, what's the given? All right. You don't care about where you have to go. You ask what's the given, and then you work and solve the problem. And that's what made Stella in this picture, in this story, the Stella's really a Renaissance woman, you know, who's ahead of her time. The other themes are how to be a good listener, because remember, not listening was something that turns out in every incident, the patients who have bad outcomes feel like they're not being heard. So how do we get the medical community to listen? And if you have a medical provider who can hear, but who can listen, but can't quite hear a patient, how do we deal with what we got in order to overcome that? Another theme is God's power to heal. And just to understand that the Lord moves people in special ways and stuff. And the last concept is strength and community. And so for Black History Month, it's really got a lot of soul. It ties you directly into that Hear Her campaign that we talked about. And again, we talked about the warning signs. The sheet, I'll mention it: headaches, dizziness, visual changes, pain in the right upper quadrant, shortness of breath. It might be heart failure. It might be pulmonary embolism. It might be fluid overload. All of those things, chest pain, any of those symptoms that we hear, we want to advocate and get that mother to move in. And again, I think our focus with the Be Admin Project is to try and help that support system, the brothers, fathers, the cousins, sisters, grandmothers. If they recognize the symptoms, that's one thing. But when that mother says something about it, it gives that support team the license to raise the voice and raise the alarm and engage with the medical community with the understanding that we will be heard, and we're not going home. We're going to make sure we heard. Okay. And that ties into the survey. I'll let you guys kind of like roll with the survey, but here's the questions. Do you know someone who had a major event? Did you know? And so it kind of educates as we go through the survey and stuff. Have you used patient advocacy? And this is just because we're still developing the team, but just with about 200 responders and stuff like that. Do you know a Black woman? And up to 60%, 62% of the respondents knew somebody who have some issues. And as you start talking about this issue, it's going to come out, because one of the things that you notice is, remember, a lot of Black folks don't believe in talking about things when bad things happen. And I literally, one of the people I work with dropped dead a week and a half after delivering. Her mother did CPR and brought her back to life. Well, when that happened, the husband, when it came for that second child, the husband didn't want her to have a second child because of that. So you need to understand, when people go through these things and go through the trauma of almost losing a loved one, or nearly losing a loved one, it has ripple effects in the support system and stuff. In terms of the issue about babies afterwards and stuff like that, again, you know, most of the people that we in the survey didn't quite know that. How familiar are you with the term preeclampsia? It ranges. And our job is to get you more familiar with preeclampsia. All it is uncontrolled hypertension and stuff. But the bottom line is, hypertension in a normal person is different from a hypertension in a mother. Because when the mothers get the hormones on for delivery, their blood vessels don't tolerate high pressures as well. So if you have a mother who comes in with a blood pressure, say 145, a sister, top number 145 over about 90, that mother's actually almost technically in a hypertensive crisis. Whereas if the average guy, or you walked in, other people, any of us on this thing walked in and had those numbers, they say your blood pressure is a little bit high. Let me check it again, and we may or may not put you on some medicines, but it's not the end of the world. In a pregnant woman, that woman will get admitted to the hospital right away and put on magnesium infusion. How comfortable do you feel? with your healthcare providers. We just wanted to gauge it, and it's just we just wanted to gauge it and get people to enter into a discussion about it. Have you ever used patient advocacy? Look at that. Most of them haven't, and I'm glad. I'm so proud of the question that you asked. I'm glad that the person on with me just reemphasized that people who work at a hospital know, but the bottom line is the greater body doesn't know that hospitals have to have someone there for that. Have you heard the CDC's Hear Her campaign? And this is where we come in, and that is 87% say no, but we're gonna change that, guys. And through God's mercy and stuff like that, and using you guys, to push this campaign out. You guys can make a difference if you don't do anything except for get more Black families to tie into the Hear Her site. The Hear Her site has posters, handouts. It has audio, video, little learning sessions. It has everything you need to run a full program and stuff. And then did you know that most Black mothers' deaths are preventable and stuff? And that comes in. So we've already accomplished our learning objectives. And what I want to just say is I hope I pushed you and encouraged you to action utilizing the Hear Her campaign by CDC. And the reason I chose the Hear Her campaign by CDC, I'm not getting paid by them. I'm not on any grant. It's just that when I did my research, the message that we have in the book basically lines up with the CDC. The other thing is April 11th through 17th is Black Maternal Health Week. I hope that each one of you guys do something there and stuff. In closing, I'd like to just play one little short how do I say? In closing, what I want to do is just play one little hold on one second. I like to play one little video. And do you have the other video that I have of the closeout video? It's for Black History Month.
Let me check. One moment.
Yeah. Let's see how to. Okay. Let me see if I have it here.
Is it the Black History with Dedication video?
Yeah, it's a Black History with Dedication video. And
Perfect. I'll pull it up.
What it is guys, if you can do me a favor and post it around and stuff, play it for everybody, and we'll see what we have and stuff, okay?
February is Black History Month, a time when we look to our past and find causes to celebrate, a time when we prepare for the future, and a time when we take a true look at our present condition. Truth is, there is a crisis in American women's health. Black women die during pregnancy at 3 times the norm, and most of the deaths are preventable. I am Stella, a midwife who lived 100 years ago in Middle Georgia. For Black History Month, I want to share my short story with you. It's in the book titled, The Quilt Makers, The Art of Hearing a Black Mother's Cry by Dr. B.K. Edmond and Miss Cassandra Edmond. In it, I show you how to use Black history and traditions to protect the mothers in your family. You can download and listen to the audiobook from Audible, Amazon, or iBooks. Part of all sales go to support the improvement of mothers' health outcomes. Visit our Instagram site at B Edmond Project to learn about other culturally inspired ways to improve your health.
Okay, guys. And that, my friends, is kind of, I think that's kind of it. I hope that you guys, I hope that I hope that you get a chance to listen to it. It's my pleasure to be here. I'm putting a little copy on the thing. You can post through your Facebook or whatever on that with that link I just sent, and I sent another copy of it. Are there any questions before we close out, guys?
I had a question.
Yes, ma'am.
Was the wise men, did you come up with that, or did you get that from someone else? Because when I quoted, I want to know, should I quote you or should I quote someone else?
For me, it was just the way it happened with me was when I actually, for me, I came up with it myself, because what happens is I try to tailor my discussions to audiences. So that's why I say, well, when I'm talking with somebody who's, I knew I was talking to a Christian audience. So because I'm talking to a Christian audience, how can I get something that you can relate to easy, that helps me to communicate? effectively with you. So, and that's why that came. So I actually developed that on my own and stuff.
Awesome. That's awesome. I loved it. Thank you so much.
Remembering it, you know what I mean? You know, and understand everything they need. They needed safety. They were getting hunted down by Herod. They needed money, resources to run, establish a safe community. They needed to be able to travel, travel to the hospital. Now you need resources. And one of the things that's happening in the Black community, quite frankly, is a lot of women are deciding to go back to their parents' house for about a period of about, you know, a couple of months, about 2 months, you know, and go back to their mothers and fathers' house, which are a little bit more established, to have their children. Because you got to remember, you know, if you're going to be a grandmother or auntie, you may have let's talk about your environment. It's a safe environment. You have more resources than the mother. It's a safe environment. You have transportation. A lot of time, the daughter has been going to the hospital in the area, so they're familiar with the medical scene in the area. The mother and father, if they're coming, say if the grandmother and grandfather, you're using resources that this grandmother and grandfather have been using for decades. Okay, and it almost puts a little bit of an umbrella under that, over that new mother and stuff. It's not to say that a young father and mother shouldn't be doing it out away from families, but the reality is in order to overcome this issue, it's going to take some family weaving together. It's going to take us working together. And that's really what happens in the book. And what happens in the book is basically you have a community that says, look, anytime a sister runs into problem, we're going to bind together as a community to make sure that she's heard. And the only thing that differentiates them, they have a better outcome, primarily because the medical system is forced to hear them. And there are other shades of it. The people in there, if it sounds like I knew them personally, I did. I have an Uncle JT, I have an Uncle Lou, Aunt Flossie Mae. Alta is one of my god sisters, and Aunt Annabelle is her mother, who's a role model and stuff like that. That's my sister's godmother. We drew from people that we knew and understood and stuff. And I hope that the love that we tell in this love story, you know, helps you guys to carry on. But more important, I hope that the story that we told today moves you towards action, understanding that we're addressing a problem that's already been solved by most of the more wealthy countries in the world. So don't let people feel try and talk to you as if this thing can't be fixed and can't be addressed. And there's also a time for faith and stuff, okay? And also a time for you to understand that, you know, you can move, you know, make your plan, figure out where you want to jump in, and jump in understanding that you are going to be successful and have the ability to be successful with this. If you go to if you can put my website, the B Admin, www.thebadminproject, let me see, project.com. That's the site. And my team, well, not product, but project. I apologize. But and I think that's it. Any other questions you can think of? Okay, then in that case, I'm going to get on down and continue to take care of patients. If you wanted
I
that,
just wanted to say, I'm sorry, I just wanted to say one thing. This was an excellent presentation, very informative. And now I feel like I can go and tell people what to do next, you know, when something happens and how to make formal complaints. Because I didn't think about calling the administrator on duty.
yep,
That would make people move. Thank
move.
you so much. This was excellent.
Yes, 100%. And we can make a difference. Other than that, you know, like I said, spread the word, spread the text. And also we give half of our proceeds go to Black Women's Wellness Alliance for Los Angeles and stuff. So, and so purchasing books and purchasing the audio book and such, you're actually helping to directly address this issue and stuff. I make my money doing cardiac anesthesia. Okay. But this right here is a labor of love. But for some reason, I think we're really, really on to something. So let's teach people how to focus on that 6 weeks. Let's get them conversant in the symptoms. And I hope you enjoy the love story and that you read. And I hope it adds to your day. All righty.
Let's thank Dr. Edmond. Round of
Thank you,
applause.
Dr. Edmond.
Thank you so much for joining us. It was excellent presentation.
Thank-
Selma.
All right, then. Thank you so much. I'm gonna head on out. God bless
Thank you so much. God bless you.
Thanks.
Post some things and send them on around. We're available for speaking and all that other stuff too. Sometimes if you get the notion, okay. But God bless all of y'all, man, and thank you for what you do for our community, okay. And we really get it and stuff. I really get it. All right. God bless. Thanks, Dr. Mel.
All right. Take care.
Mhm.
All
It
right.
looks like
thanks,
Dr.
everyone.
Clark, Crystal has a question. Her
Oh,
hand's
okay.
raised.
Yes. Miss
I-
Crystal? Yeah.
I'm sorry, I was trying to get myself off mute. I just wanted to, say it was such a great presentation and just share that, our daughter actually experienced postpartum preeclampsia after she had a child. And thankfully it was a good outcome. She was taken to emergency room, was hospitalized for about 2 days. She was sent home, but what really was helpful is they sent her home with a home blood pressure monitor and told her, if it went back up again, what to do. She ended up maybe 3 days later with a severe migraine. We checked the blood pressure and it was like 200 over 120. And so we sent her
Wow.
straight away back. And that time she stayed in the hospital. I think they kept her for about 4 days. But, it does take the whole family because, we had to care for the baby while she was in the hospital being cared for. And, you just don't realize the seriousness of these type of situations until listening to some of the stories that have been shared.
I think, thank you so much for sharing that. And I think part of the issue is we think of pregnant women as healthy, right? And then if you're not being encouraged to share what's going on with you and your symptoms are minimized, you want to believe that you're okay. So if somebody minimizes your symptoms, then you're less likely to push and advocate and say, no, something is really wrong. And then number three, there's just the phenomena of Black people, and in this instance, Black women not being heard. So there's strength in numbers. And that's why I think it's really important for families, for advocates to really band together to be able to change that power dynamic and make sure that we're heard when there even is a minor complaint. So thank you so much for sharing that. All right. Thank you, everybody.
Thank you.